Much, Norman and John, for inviting me. This is a wonderful meeting, wonderful event. I feel very fortunate to be part of this great group of friends and colleagues. So I was asked to talk about really who needs anti-PD-L1 therapy in early stage disease and for how long. So I was very excited to go through this talk. You've heard a lot of this data already from the wonderful talk that Dr. Jorgens has given you, but really wanted to try for the next 15, 20 minutes to dissect the data that we have available to answer these questions. So here are my disclosure. So setting the stage, you know this very well. I love this cartoon from Christian Blank from a few years ago to really tell us with all the standard of care that we have available now, so between neoadjuvant, adjuvant, and perioperative, why, at least to me, the neoadjuvant setting perhaps has some advantages. So you all the biology of this approach very well. Adjuvant therapy can allow us to eliminate micrometastatic disease post-surgery. We have a shorter time to surgery. It can really allow us to restore the anti-tumor immune response after a surgery that could be immunosuppressive. In the neoadjuvant setting, we have several opportunities. We can start treatment against micrometastatic disease early on. We have a tumor in place, which is intact, with a vasculature and immune system that are intact. We also know from Swanton's work and other groups that when the tumor is intact, still in place, we should have the highest tumor neoantigen burden as well as lowest clonal resistance. The beautiful opportunity to perform translational analysis in pre- and post-therapy samples, and then the opportunity to rely on potential surrogates of clinical efficacy, MPR and PCR, to predict response in a rapid fashion. And then, of course, in the perioperative setting, we can administer immunotherapy throughout the surgical setting to continue to hopefully kill micrometastatic disease. I'll be very fast here because who needs immunotherapy will embrace, based on the standard of care, the adjuvant setting, the neoadjuvant setting, and the perioperative. So I'll start off with the adjuvant setting. You have seen this data again from Dr. Jorgens. This is the IMpower-010 data with adjuvant atezolizumab following chemotherapy for patients with resected disease, positive disease, PD-L1 positive, with an advantageous DFS, as you can see from the middle, and greater separation of the curves for patients with high PD-L1 expression, 50% or more. We have a trend towards OS improvement. We have seen this data recently in Annals of Oncology, but we don't have a statistical significance yet. And then again, you've seen this data, the pearls from the Keynote 91. You've seen the advantage in terms of disease-free survival from adjuvant pembrolizumab post-chemotherapy in resected patients, all comers, although surprisingly really not a magnitude of benefit in the PD-L1 population, 50% or greater. You've seen the CheckMate 816 data. We know a quarter of the patient achieved pathological, complete response. You've seen from Dr. Spicer just a week ago or so the updated EFS data for year, very encouraging. So long-term benefit from only 3 cycles of neoadjuvant nivolumab plus chemotherapy for these patients. And you've seen also the overall survival data and the lung cancer-specific survival, which to me is a very important endpoint in this setting. So very encouraging separation of the curves for these patients. And you've seen the Keynote 671 data last year at ESMO, again from Dr. Spicer, with an updated EFS. You see a very nice separation of the curves on the left. And then the only trial so far with perioperative immunotherapy that has demonstrated in decades, really, a overall survival improvement in the adjuvant setting. The CheckMate 77T, Dr. Jorgens has mentioned this to you. You have seen this data has been published, so I want to get to the subgroup analysis, but you can see here from 4 cycles of neoadjuvant, up to 4 cycles neoadjuvant chemo plus nivo, followed by surgery, and 1 year on nivolumab. You can see a very similar overall benefit in terms of EFS as compared to the 671. And you can see from the landmarks really an over time benefit from the perioperative approach from randomization. So who needs anti-PD-L1 therapy with all this data that we have available? So let's take a look. Let's dissect in a purely exploratory fashion what we have in terms of staging. So this is a table presented last year from Nick Girard at the European Lung Cancer Conference. So from the 3-year survival update of the Checkmate 816, you can see from the hazard ratio and the forest plot here, you can see perhaps at least numerically a greater magnitude of benefit from the neoadjuvant Checkmate 816 paradigm in patients with stage 3 disease as compared to stage 2. If we do the same type of exercise in patients treated as part of the Empower 010, you see that perhaps there is a greater magnitude of benefit in the lower stages, so stage 2, as compared to stage 3. So let's keep this in mind as we move along. We did do an analysis, an exploratory analysis in the Checkmate 7070 purely based on stage. And you can see from these curves that definitely, again, in a stage 3, there is a very nice separation of the curves. And perhaps we need more time for stage 2. But definitely it's clear, again, that with this approach, patients with larger disease, more nodal involvement seems to really benefit from this type of paradigm. So what about if we go deep into the stage 3 and look at the N2 versus non-N2? This is data that has been just presented last week. I'm really appreciative of the tremendous effort that the team put together to really dig deeper and better understand what is the benefit of this approach in what we talk about at Tumor Board every week, all the time. And so you can see that for patients with stage 3 N2 disease on the left, 70% in the Nivo arm as compared to 74% in the non-N2 Nivo arm, and 45% in the placebo arm and 62% in the placebo arm in the non-N2 remain recurrence-free after 1 year from randomization as compared to placebo. And you can see in the N2 population how in the placebo arm, there is definitely a poorer prognosis, which is, again, consistent with the poorer outcome given the more extensive nodal involvement. So definitely a very encouraging hazard ratio if we look at the perioperative approach here in the stage 3 N2, perhaps even greater than the non-N2. And if we look at the single and multi-station, very nicely, we see encouraging hazard ratio 0.4 overall, 0.49, 0.43 for single and multi-station. And hopefully this is a paradigm changing really for our surgeons and our teams to really start looking at these patients as potentially resectable rather than dispositioning them to a specific type of paradigm. We did take a unique approach here. We did look at the EFS landmarked at the time of surgery as compared to randomization in an attempt really to try to understand the contribution of adjuvant component to the clinical benefit. And I think these curves, especially for the N2, are self-explanatory. When you can see the magnitude of benefit from this paradigm with Nivo, perioperative Nivo, specifically perhaps from the adjuvant component, although we cannot really, with this trial or any other perioperative trial currently existing or read out or will be read out, we cannot really attribute the benefit specifically to the adjuvant component. And then if you look specifically at the single and multi-station, please do appreciate the separation of the curves for patients with extensive nodal involvement, especially in the multi-station with the impressive hazard ratio, almost close to a targeted therapy type of hazard ratio. What about the EFS and DFS by PD-L1 status? I think we are all very accustomed to see a very nice separation of the curves in PD-L1 positive patients. But perhaps if we look at the 816 as well as the Empower 010, we see that there is benefit in the PD-L1 positive population, but really not much of a separation of the curves when we look at the PD-L1 negative. But if we take a look at the perioperative approach, this is just an example, but we have seen the same results with a 0.75 hazard ratio for the 671, if I recall correctly. You can see that in the PD-L1 negative population, we start seeing a benefit that we perhaps have not been able to see with a neoadjuvant or adjuvant approach solely. And so Dr. Spicer and his team, we were all very fortunate to be part of this work, took a very unique approach, did look at all the trials available with chemoimmunotherapy, neoadjuvant or perioperative versus chemotherapy alone. And you can see here how there is a benefit from this approach in the stage 2 as well, and in the PD-L1 negative population. And this is something that's very important because it's important to think about this patient population to benefit from this approach rather than think of the PD-L1 as a biomarker to actually take this approach away from these patients. What about the PCR to decide who needs therapy or not? You've seen these curves presented by Mariano Provenzio last year at ESMO. As part of the 3-year survival updates, EFS and OS, we know that patients who achieve a PCR do well in both arms, and so there is a debate on whether we want to continue or not. I think that John has presented just a week ago a 95%, if I recall correctly, for OS in the PCR positive population. So hard to argue there that you really need to continue therapy. But for the non-PCR population, you can see that there is an initial separation of the curves in the 816 for EFS and OS with an hazard ratio of 0.89 for EFS and 0.77 for OS. But as Dr. Jurgens mentioned to you, perhaps now we're starting to see even a greater separation if you look at the perioperative approach. So for how long patients need to have anti-PD-1, PD-L1 therapy? So first of all, how long, to me, also covers the amount of cycles. And Mark Awad has presented this year at the European Lung the analysis, the exploratory analysis in the 77T of 4 cycles neoadjuvant chemoimmunotherapy versus less than 4 cycles. And so if you do look at the intention to treat population with the solid bars on the left part of the panels, you can see that there is a numerically lower rate of patients who achieve PCR if we don't have a total of 4 cycles. But if do patients undergo surgery, so if you do look at the true PCR rates in a sensitivity analysis, you see that there is really not much difference. And that this gives us some support in really be okay with 3 cycles as the checkmate 816 paradigm rather than 4, so that we do not jeopardize the opportunity to have surgery for these patients. Does PCR is really the only factor that matter? Perhaps no. I think that Janice Tabb and her entire team have done a spectacular work to really start dissecting how important is the residual viable tumor as a continuous variable in this setting. And you can see from this representative Kaplan-Meier curves of EFS by categories of residual viable tumor just published last year in Nature Medicine, you can see that PCR and the near PCR, so 0 to 5% viable tumor, really have the best event-free survival in the checkmate 816. 90% EFS at 2 years with 0 to 5% viable tumor is quite impressive with only 3 cycles of therapy. And you can see how those curves start dropping as the amount of viable tumor grows. Patrick Ford has done a similar analysis using the MPR. So this is the 5-year survival outcome published last year from the NIVO neoadjuvant cohort. And I think this is quite telling. So even in a chemotherapy-sparing type of regimen, you can see that patients who do achieve PCR do better than those who don't. And we have attempted an initial analysis with very early follow-up time in the NIVO-EP cohort for the new star, very early days, but you can start seeing that perhaps those patients who achieve an MPR might have a better outcome. And this data is going to be updated in a wonderful team effort at ESMO with John, Patrick, the entire team, putting all the data together with NIVO-EP, and trying to understand what the 5-year survival outcomes look like, and does that matter to have an MPR or a PCR in that setting. So for how long do we need to treat our patients with the adjuvant therapy in the context of a perioperative approach? I think Mariano Provenzio did a fantastic work with his NADIM-2 trial, so 3 cycles of neoadjuvant chemoimmunotherapy followed by 6 months rather than 1 year that we've seen in all the perioperative trials. As you can see here, not surprisingly, an improvement in the PFS and OS with hazard ratios that are actually very similar to what we see in the 77T for the stage 3 population, as this population here was stage 3 only. But what's striking is that we know that PCR is going to be prognostic for our patients regardless of nivo chemo or chemo only. But really what was very intriguing to me, and I do appreciate the importance of these curves is that for patients who did undergo surgery and achieved an R0, you can see the much improved outcomes with the Nivo in terms of PFS and OS, excuse me, as compared to those who didn't have the opportunity to complete surgery and complete the 6 months of therapy. You've seen these curves from the perioperative approach. So for PCR, excuse me, and the non-PCR, for PCR, similar outcomes with Nivo chemo, Nivo pembro. But for the non-PCR patients, you see this larger separation of the curves, suggesting that perhaps the contribution of adjuvant might matter here. And we did take a look to answer this question in terms of who should receive and for how long, and does it matter whether we do adjuvant or non-adjuvant. Please do appreciate that these are very heterogeneous groups of patients, prognostically very different, as you can see from the control curves. But if we look at the EFS from surgery, patients who had adjuvant therapy have an improvement in EFS, and also patients who didn't have adjuvant continue to receive benefit from neoadjuvant treatment. So this was the very first analysis, an exploratory analysis, that again attempted to understand the contribution of component. And if you look at the PCR and non-PCR populations within the patients who receive adjuvant therapy, you see even a greater separation of the non-PCR curves. And this stays the same if you look at the stage 3 N2 and non-N2, specifically for the N2 EFS landmarked at time of surgery for patients who received adjuvant therapy as a ratio of 0.48. So hopefully, again, this will help the tumor board to make a decision, especially in absence of an intensification strategy on trial. Perhaps patients who have this stage of the disease and who do not achieve a PCR should continue therapy. This is my last slide. There is room perhaps for a chemotherapy sparing regimen. We've seen the results of the of the Nivo EP from the Checkmate 816. I think we still have to understand who are these patients who will benefit from a dual immune checkpoint blockade only. We're not quite there yet. So this is take-home points. I think that we have adjuvant options, perhaps really an opportunity for patients with stage 2 disease. We have neoadjuvant and perioperative options, and we're learning to dissect the subgroups to understand who might benefit from a continuation of therapy as compared to neoadjuvant only. And I want to emphasize that perhaps that decision has to be really based on conversation with our patients, their needs, their goals, in addition to disease characteristics, stage PD-L1, and so forth. So thank you so much.